All right, so welcome back to part 4 of trauma. Now we're going to talk about the theories of hemorrhage control. When I started in EMS, tourniquets were considered, as an example, tourniquets were considered to be of last resort, life or limb. If you put a tourniquet on, you're going to cause them to lose that arm or leg. And we know now that's not really the case. In the last 20 years since Iraq and Afghanistan started, we've learned a lot about trauma care. So let's dive into this a little bit. Now, casualty mortality curve was developed or came about from one of the military's kind of educational expert surgeons, I guess would be the best way to call it. And I don't remember his name. This was shown to me by a pararescue medic in the Air Force. And the surgeon came up with this based on his studies. And it said that and these are your worst trauma patients, that in that first 6 minutes, 20% of them are going to die. Now, mind you, this is military, and but I still think this is an adequate description of our civilian trauma patients. We go to our worst trauma calls, and there's a portion of them who are dead on scene before we get there. So 20%. Doesn't matter what you do, they're going to be dead in 6 minutes. Okay, they're just unsustainable injuries. Now, over the next 54 minutes, all right, so that so-called golden hour, you're going to lose 10% more. You will only lose 10% more, I guess I should say, if you control arterial bleeding and their airway. And this is BLS, so tourniquets and nasal airways. Positioning, right? Recovery position, if you want to call it that, left lateral recumbent, whatever. Okay, but if you do good arterial bleeding management and good BLS airway management, you're only going to lose 10%. Well, that's kind of a ugly number to think about. 10%, 10 out of every 100, 1 out of every 10. But if you don't control those, that 10% is going to be exponentially higher. Okay? Now, the next 5 hours is ALS. If in the next 5 hours you can control breathing and control shock through the use of endotracheal tubes and ventilation and some fluid and some blood products, then you will lose another 10%. Now, the military was looking at this because we think of military casualties as, well, not a big deal. They'll just call a helicopter. The helicopter shows up and they take them to a trauma center, which ideally is what happens. But what they were finding in Afghanistan in these mountain areas is that some of our helicopters don't do well at those altitudes. They can't pull the weight of people, in and out of those mountain elevations. And they may not have the helicopters they need available that can make those recoveries. And plus storms. The mountains of Afghanistan get some horrific snowstorms. They get some horrific, sandstorms, whatever it is. So there were times where these critically injured patients were being stuck on these hillsides for a day or 2 or 3 before they could be extricated. So they were trying to figure out where we can keep these folks alive while they wait for extrication to definitive care. Once we can get a helicopter to them, they get the best trauma care on the planet. But in that time where we're stuck with them and our medics are stuck with them, how can we make a difference? So, that's in that first 54 minutes of that, that 54 minutes of that first hour, that's why all our troops are taught tourniquets, nasal airways, right? Then our medics, can do things, plasma, albumin, blood products in some cases, advanced airway control, okay? chest decompressions, chest tubes, all right? Then at that 6-hour mark out to 24, they're not going to lose any more people. Well, so what happened to the golden hour? Well, you got to remember, from 6 minutes out to 6 hours, we're going to lose 20% of our most traumatic injuries. So in that 6 hours, that 20%, that's where our trauma centers really make a difference, right? Because if we can keep 2 out of every 10 alive with early trauma care, and that's why I tell you, it doesn't matter, you know, driving an hour to Portsmouth versus 35 minutes to Huggins doesn't matter, okay? If that 20 minutes is that big of a difference, they're going to die anyways, okay? So then at the 24-hour mark, they start to lose another 10% due to sepsis. So this PJ that I was talking about said that what he did was he had in his helicopters, he had a backboard for moving patients, right? On the backboard, he had taped fentanyl, and he had taped a ketamine lollipop, and he had on there taped also was the first dose of antibiotics. I don't remember, it was Ansaf or something like that. So that at the time of basically accessibility to an advanced medic, boom, 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 pain meds, pain control, infection control, and they were trying to swing this curve into a better angle. So I'm not saying you don't need ALS for the first hour. I'm saying that you can take a patient to the right facility with some good BLS, and you can maybe make a difference in that 10% with some good ALS, okay? Now, leading cause of death during pre-hospital period in both military combat and civilian trauma cases is uncontrolled hemorrhage. This was from a newspaper called the Army Times. I believe it was in 2007. At this time in my career, I had a little ongoing insomnia, and I was doing a lot of kind of research and stuff at night when I should have been sleeping. And I was an Army medic. And so I kept up with some of this because I knew the Army, historically, the military, is our trauma lab. And what happens, you know, in Korea came home to the US. What happened in Vietnam came home to the US. And what's happening in Afghanistan and Iraq was coming home. So I was kind of keeping track of this, and the Army Times had this great article. Now, the use of tourniquets was first documented on the battlefield back in the 1600s, okay? But somehow we got away from it. And, you know, like I said, in the 80s, I was taught, oh, it's last resort, life or limb. But when I started preaching tourniquets right around 2007, I'd ask students and refreshers, what have you been taught about tourniquets? And people were telling me, oh, they're evil. I'm like, what do you mean they're evil? Well, my instructor said they're evil and don't use them. How did a piece of cloth become associated with Satan? I don't get it. But we were being taught bad things, and it's kind of like that secret, you know, when you're in school and they start the secret on the other end of the room, like the school bus is yellow, and by the time it gets 30 kids later, it's lunch got blown up in a airplane crash, right? Things change from speaker to speaker to speaker, and from teacher to instructor to mentor to, you know, it became tourniquets are evil. Crap. No, they're not. So 2007 at the Virginia Tech shooting, this Eagle Scout, college student, took a round to the leg and knew that, in the interview I read, he knew he would be dead before the scene was secured by police and EMS got to him. He had been taught in the Boy Scouts and the first aid how to make a tourniquet. He used an electrical cord, saved his life. Guess what? He didn't lose his leg either. An electrical cord, he didn't lose his leg, okay. Now, Army Times said that the new tourniquets are one of the Army's 10 greatest inventions. I don't know about you, but again, I said I was in the Army. I kind of liked Hueys and Black Hawks and Apache helicopters and Law rockets and M60 machine guns and saws. So to make this little, okay, yeah, they charge $30 for them, but this little 25-cent piece of cloth and plastic or metal, Army's greatest inventions? That got my attention. Now, what they said was in a retrospective study of Vietnam and Somalia that about 7 to 10% should have survived with the use of a tourniquet. So if we look at Vietnam and Somalia together, we're talking 60,000, about 75 in Somalia, the rest in Vietnam. Let's use 10% because it makes my math easier. 10% of 60,000 is 6,000 people could have survived, should have survived if a tourniquet had been used. Somalia was what, 1993, okay? So 6,000 people. How many lives would have been different if those 6,000 had survived? And the numbers are staggering. So this realization resulted in a shift in attitudes and decided tourniquets weren't in fact bad. Everybody should have one and be taught to use it. GEMS, Journal of Emergency Medical Services, an EMS magazine that we, should read and, and have experience with. They did a study and their statement was uncontrolled hemorrhage from isolated penetrating extremity wounds. We're not talking the gut and chest, but from extremity wounds can result in 100% mortality, but significant controversy exists. They looked at 14 civilian patients who died from that isolated extremity injuries, even though they got to a hospital that had an OR and that, should have been able to survive. None of those 14 had a tourniquet applied. Of those 14, 8 of them had an injury location that should have had a tourniquet used. So in theory, 8 of those 14 should have survived. That's 58%. 58%. That's half of all dead extremity patients should have lived, okay? Why? Well, they're evil. Boston EMS did a study. This was in the same time frame, 06, 07. They had 11 patients, average age was 27, all males, right here, hold my beer. Half of them had gunshot wounds, a bunch of them had stab wounds. All of them had major artery injuries, and half of them had major venous injuries, okay? Scene times were 3 to 17 minutes. I don't care where you are on the planet. You can be off scene with a gunshot wound to the leg or a stab wound to the arm in between 3 and 17 minutes, right? You got a stab wound to the arm and the guy's too big to, there's only 2 of you and you can't carry him down a flight of stairs. Guess what? Come on, walk. Let's go, let's go, let's go. Okay? Transport times to a level 1 trauma center. Remember I said in Boston, at the time there were 6 level 1s. Transport times 4 to 10 minutes. You can't do that in New Hampshire, Maine, Vermont, right? Montana, Wyoming, whatever. It's going to take 5 to 10 minutes for the helicopter to get the dispatch info, do their pre-check, and lift off. Tourniquets were on between half an hour and 3 hours, roughly, right? 37 and 167. All of these 11 had all the lower extremity injuries, had full neurological return after. Now remember, there were 11 patients. 1 died, but he was a trauma code on scene. Trauma codes do not survive, right? On scene, trauma codes don't survive. So those are pretty good numbers. 10 living patients that needed tourniquets had tourniquets applied. All 10 survived. All had full neurological return. 14 patients died. 8 should have had tourniquets. All 14 died. 100% mortality versus, okay. Now, Boston Marathon. So that study, remember this study was in 07, 08, 06, somewhere around there. We fast forward to 2013 and the Boston Marathon bombing. 27 patients or 27 tourniquets were required. 26 of them were homemade. So this is 6, 7, 8 years later, after Boston EMS did a study showing that tourniquets save lives. This is 2013, after the US military had been preaching tourniquets for about 7 years. Yet they did not have tourniquets in the city of Boston. Now, where did I get these numbers? In March of 14, at the Eastern Association for the Society of Trauma, East, Dr. David King, who was the trauma surgeon on call that day for Mass General, and was also a U.S. Army surgeon who had deployed, made this presentation to this conference. And he said, "It is abundantly clear from the literature that improvised tourniquets almost never work. The fact that every soldier downrange has one in his pocket, and we couldn't muster up more than one in the city of Boston is a shame, and we need to rectify that." Let me translate that for you, okay? Improvised tourniquets, your cravats and a pair of crash shears, your cravats and a stick, belts, okay? Improvised. The fact that every soldier downrange, that means that every soldier who is in harm's way, deployed in harm's way, but in the city of Boston, how many 100,000 people are there? How many ambulances do they have in the city of Boston on a normal basis? And then how many were at, and this wasn't just Boston EMS, right? Because at the marathon, they bring in ambulances from all over Northeast Boston to cover that. One frickin' tourniquet. Absolutely a shame. So they didn't learn their lesson. Now, this was in the Annals of Surgery in 2009, January of 2009 even. And Annals of Surgery is the surgeon's professional journal, not military, but surgeons as a whole, okay? And this was a study down out of Fort Sam Houston, the home of military medicine now. All the military medics and medical folks go there for training regardless. It's a joint base now. They looked at 7 months in Iraq in 2006. They had 2,838 injured and admitted civilian and military casualties with major limb trauma. 8% of them, 232 of them, had 428 tourniquets applied on 309 limbs. Multiple patients had multiple limbs that needed multiple tourniquets. We'll come back to that in a second. Results, 31 dead. So of those 232 that had tourniquets, only 31 died. That's 13% mortality rate. But we know if you don't have tourniquets, mortality rate's closer to 100. And so their statement was that when tourniquets were used, when shock was absent, strongly associated with survival. So in other words, tourniquet early, before they lose a lot of blood, before they go into shock, and they have a 90% survival rate. That's great. Now, I asked this PJ about this multiple tourniquets on multiple limbs. And he said that he had been in a firefight where they had shot this person in the thigh and put a tourniquet on, then packed the wound with a hemostatic dressing, and then put a second tourniquet on the top as a pressure dressing. He said that might account for some of it. He thinks that some of it is that people were putting tourniquets on and weren't getting them tight enough, and then instead of tightening them more, or they couldn't get them tighter, they put another tourniquet on. Could be. I watched a movie, and it was based on reality, on a British para regiment, parachutist, airborne regiment in Afghanistan, and they wandered into they were on patrol and they wandered into a minefield, and a bunch of these guys took hits, and they ran out of tourniquets. Everybody had tourniquets, but they were putting multiple tourniquets on the same leg or the same arm. And as more and more people got injured by these mines, they ran out of tourniquets. And one of the issues was they brought a helicopter in, and the down blast from the rotors set off a bunch more mines. And so they took a bunch more hits at that point. So my view on this, from talking to him and seeing this movie, is that you put a tourniquet on a leg or an arm, you put that on just as tight as you can and reassess it, right? We're supposed to reassess our trauma patients every 5 minutes. Reassess that tourniquet, because what you're gonna find is that you can tighten it a little bit more at the 5-minute mark, and at every 5-minute mark, you might be able to tighten it a little bit more. Okay, as muscles relax, that tourniquet will not be as tight as it was, and you can tighten it down more. So keep that in mind, please. Now, they said that if the tourniquets were put on in the hospital, in the ER, there was 24% mortality. But if we did it in the field, there was only 11%. So again, the sooner you put the tourniquet on prior to shock setting in, the higher the survival rate. Now, they did have 5 patients who should have had tourniquets and didn't. All 5 died. 100% mortality versus 13. Now, 4 patients did have what they call transient nerve palsy. What that means is they had a little numbness and tingling at the site of the tourniquet, but it was transient, which means it went away. Hey, I'm okay with that. Put a tourniquet on my leg or my arm. Let me have a little numbness and tingling that goes away, but save my life. No amputations were caused by the tourniquet use, okay? So their conclusions: tourniquet use when shock was absent, strongly associated with saved lives, strongly associated with life-saving by using it pre-hospitally, not waiting for the hospital. No limbs were lost, and that we need to field more tourniquets. Now, there was another study published a year later out of Fort Lewis, Washington, and the percentages were identical. The numbers were identical. Okay, these are good studies. This isn't 11 in the city of Boston. This isn't 14 in whatever other city that was. These are thousands. These are good numbers. Tourniquets need to be used. Now, remember, this was 2007 or 2009 that I was doing this and reading this stuff. And I was trying to talk my boss into tourniquets at the time. My boss at the time was one of the smartest guys I know. Had run flight services, flight medic, flight nurse, master's degree in disaster management, right? Smart dude. And he'd go, you know, I don't know. I know what the studies say. I just can't get over the idea of that tourniquets are evil, you know? Shit. So we went to a motorcycle accident. Drunk guy hit a car, tore his leg off. He had all kinds of other injuries, TBI, tension pneumos. He got RSI'd. We, you know, put decompressions, needle decompressions in him. And then we're looking at this leg that has a great, the BLS did a great job with it, great pressure dressing, but this multi-trauma dressing was like a big wet, sopping wet diaper. And I was like, oh crap, we need a tourniquet. And we didn't have one. So we made one with a cravat and a pair of crash shears. And when the helicopter crew showed up, they were like, ooh, a tourniquet. We've never seen one of those before, right? Well, the flight nurse called me about 2 hours later and said, hey, just so you know, that tourniquet didn't work. I said, what do you mean? And she said, well, we got to Portland, the helicopter was full of blood. I was like, why? I said, what do you think? Elevation changes, atmospheric pressure? She goes, I don't know, it didn't work. I was like, okay, thanks. And so I started thinking about it and realized that the issue was cravats, triangular bandages, are made out of cotton. Cotton stretches. And they were in a helicopter. They could not get down to where the tourniquet was to assess it and tighten it up. So if you're going to make a homemade one, you better assess it every minute or two, okay, because cotton stretches. So then we went to, and my boss was like, oh, geez, I know. And then a couple weeks later, we had a train event where somebody got hit by a train and lost a leg, mid-tib fib, and we needed another tourniquet and used a triangular bandage, a cravat, and a pair of crash shears, and I tightened it as tight as I could, waited a couple minutes, tightened it some more, told the helicopter crew coming in what the deal was, and they tightened it some more, and it worked, okay? So a couple months later, on my local rescue service, fire department that I was a member of, and I was the EMS lieutenant for, I had bought regular commercial tourniquets. We had a guy at chainsaw kicked back right into his calf, and we saved his life with this tourniquet. And you know, he needed 8 units of blood in the ER and in the OR, and it took hours to find a vascular surgeon, but we saved his life. And we got a note from him a few days later saying, hey, thank you for saving my life and my leg. So the tourniquet didn't cost him his leg. My boss, by this point, at the hospital I worked for, had said, okay, let's buy tourniquets, and we put them on the ambulances. And he and I were working a Sunday shift together, and they had a shunt placement patient in the unit recovering, and the shunt let go, and there was blood flying all over the room. And they were doing old school pressure points and direct pressure, and my partner and I walked in to see what was going on, and my boss and I, and she was lying in a pool of blood. The bed was a pool of blood. And the nurse was on the phone with the surgeon who put the shunt in, and I said, hey, she needs a tourniquet. And the nurse said, no, it's okay. She doesn't need a tourniquet. I just talked to the surgeon. He'll be here in half an hour. I said, yeah, she'll be dead in half an hour. And the little old lady patient goes, yeah, I'll be dead in half an hour. And my partner looked at me. You gotta remember, hospitals are different places. You got to have orders to do stuff in a hospital. But my partner said, who was the boss, the manager for EMS, said, go get a tourniquet off the truck. I'll take the heat. I went out, got a tourniquet, came in, put it on, click, 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 click. Bleeding stopped. 2 hours later, the surgeon comes to the ER and says, hey, where are those paramedics? I pointed at my boss. I go, there he is. And the surgeon walked up to me and stuck his hand out and said, thank you for saving her and me. Didn't lose her arm. In fact, she got to use the shunt 30 days later when it was healed, okay? And then and this was all within about 6 months. Fast forward, I don't know, 6 or 8 years later, and we're dispatched to a call for a guy who's fallen and hurt his knee. He's had a recent knee replacement. Fire chief gets on scene and goes, oh, he's got blood everywhere. So, yeah, right. We pull up and, oh, yeah, there was blood everywhere. His knee replacement was a couple weeks old, and when he fell, the surgical line opened up. The scar, the surgical area tore open, and he tore a big venous vessel, a big vein in there, and there was just blood pumping. And tourniquet, and we took him to Dartmouth and saved his life. So that's 5 for 5. All 5 of these were fatal events without tourniquets. All 5 of them, we saved their life. All 5 of them had full use of their extremity afterwards. I'm a big fan of it. I've been preaching tourniquets now for about 13 years. I will go any place in New Hampshire and teach tourniquet use, okay, for free, because I believe in it that much. Okay, correct use, you have to stop the arterial flow. If they're too narrow, they'll cut into the skin. But remember the Eagle Scout, he used an extension cord, okay? The wider it is, the more pressure you need. So people are like, we don't need tourniquets. We'll just use a blood pressure cuff. It's too wide. And all of our blood pressure cuffs leak. Buy a tourniquet. All right, so part 5, we're going to go into the actual application of tourniquets and hemostatic dressings.